So it's my pleasure to introduce Dr. Mike Caldwell and this talk on treatments of individuals who have elevated youth, who have elevated either what we would refer to as callous and unemotional traits or the precursor pre-psychopathic or psychopathic-like traits. We'd like to try to avoid the use of the term psychopathic when we work with young kids. And the reason for that is because there's a long history, 200 some years, in psychiatry where individuals with these symptoms have been classically determined to be untreatable. And so this was really borne out in the psychodynamic era by psychoanalysis. Never really proved quite effective at treating individuals with psychopathy. In fact, it was Cleckley who said that individuals with psychopathy, if anything, they just take an egocentric interest in their client doctor-patient relationship, and if anything, they get worse. And they're more likely to get elevate or escalate their attitudes and behaviors and become even more likely to get themselves in trouble. And so, as you know, my lab has been studying psychopathy from a neuroscience perspective for the past 15 years or so. And I've always thought that there's got to be some sort of treatment that could be developed or some sort of program that could be developed. And I guess it was about 7, 8 years ago, this paper came out. Has it been 10? I don't know. There was a paper that came out that really suggested that there might be some great ways of reducing recidivism in kids who have elevated psychopathic traits. And Mike Caldwell was the first author on that paper, and I started hounding him about the data and calling him up and talking to him and inviting him to talks and lectures and other types of things and bugging him about it, and he's kept publishing and publishing and publishing. And so he's going to tell us about what I think is the best evidence-based treatment program in the world for treating the highest risk kids pretty much in the world. And he is on the faculty at the University of Wisconsin-Madison, and he also is the research psychologist at this Mendota Juvenile Treatment Center. And so I'd appreciate it if you'd all join me in a warm welcome for Dr. Mike Caldwell.
Okay, well, check's in the mail, Ken. Thanks for that. I'll just begin by, I'll jump right in. This program, Mendota Juvenile Treatment Center, or MJTC, was created in 1995. It opened in November 95. Wisconsin, like a lot of states, was having a jump in juvenile violence around that time, and they passed a sort of get tough on juvenile crime legislation, but there was some concerns about truly mentally ill youth being lost in the system and that kind of thing. And so they created this very odd hybrid in which the Department of Corrections funded a secure, maximum security correctional facility for juveniles, essentially a little juvenile prison. But it's housed on the grounds of the state hospital, the psychiatric hospital, and the staff are employed by the psychiatric hospital, and the hospital operates the program. With the legislation, the governor at the time required us to do outcome studies as part of legislation, and so that's how I kind of got into all of this. As you can imagine, well, this kind of is a breakdown of the way the two programs compared. Now, I'm going to talk mostly about studies that go back a ways, and the program and the situation in Wisconsin has changed quite a bit. But at the time that most of these studies were done, we were talking about MJTC had 15-bed units that were single bed wet cells. The secure units from the juvenile corrections institutions, the JCIs, generally had 40 to 50 kids that were double bunked. So very different kind of environment in the two. At the time that a lot of these studies were done, they only had one 8-hour-a-week psychiatrist available for about 400 to 500 kids. As you see the breakdown in mental health services in the two settings, you can see that if you're in juvenile corrections, you're going to be sending kids to this facility just for medication adjustments and psychological evaluations and those kinds of things. And that's exactly what happened. One of the key differences, though, is that the security cottages and the JCI were pretty much always run by a security person who had come up through the ranks, and MJTC was administered all the way through by people with a background in adolescent psychiatry and adolescent development. Of course, if you're in the Department of Corrections, you're not too thrilled about writing a check to the Department of Health, Family Services. So they retained full control over who came, which kids came to MJTC, and when they came, and when they came back. And there were not only no screening criteria for the kids that came to MJTC, any of the things that normally would screen a kid out of a mental health setting, like he's got cancer, or he's got an IQ of 22, or he doesn't want to be there. Any of those things might be one of the reasons they would send a kid. They sent all kinds of kids, including kids with cancer, any kid that was a problem. But the guiding principle, as it was stated to me, is we just pick out our worst kids and we send them to you. They just got the kid they wanted out of the building the most, that's the kid they sent to us. They did not send us kids who were depressed and sitting in the room and crying and wringing their hands around. They sent us kids who were tearing the room apart, flooding the cells, throwing urine through the trap, those kinds of things. And they also, at the first stage, in the initial stages, the way the transfer went is they would call us up and say, we're sending you Joe, send us Bill, no discussion. And so as it evolved, our relationship improved to the point where now there's usually a discussion back and forth about what kids are going to benefit and what kids are not. This is pretty much of a typical breakdown for Wisconsin in juvenile corrections. About half are African American, a lot from Milwaukee County. Milwaukee County's public school system only graduates about 40% of the kids that start out as freshmen. So there's a lot of reasons for that. But you can see now the MJTC sample tended to be a lot more violent than the population in the JCIs as a whole. About half had hospitalized or killed a victim for most of these studies. Around the time that there were 4 of us in the room that were planning MJTC. And we asked a psychologist to do a literature review and tell us what programs or what techniques might be useful. And she came back and basically went through about an hour and a half of reviewing the literature and basically said nothing is effective with these kids. And Greg Van Rybrook is a colleague of mine who was also in the room. And when she left, I turned to him and said, my God, that was depressing. And he said, yeah. And I said, let's not talk to her anymore. He said, yeah, we won't talk to her. So we never talked to her again. But at the time, there were a number of other broad studies that were coming out saying essentially the same thing. There was no effective treatment for adolescents who were violent. And there was a study, or a summary published in American Psychologist right around this time. This was also around the time that John DeLilio was saying he wouldn't work in juvenile corrections anymore. In a decade or so since then, there have been this group from the American Psychological Association that have done several studies, several meta-analyses, and they have identified 3 approaches that seem to be effective with aggressive adolescents. There's a lot that are effective with 10-year-olds, younger kids, and that you can deliver in a family setting. Functional family therapy, multisystemic therapy, and multidimensional treatment foster care. As you can see, functional family therapy and MST are both delivered in the family, in the community. And so MJTC is the only one that's in an institutional setting. But in spite of that, there's a lot of common features across these 4 approaches. I'm going to talk just briefly about some of those. All 4 of these approaches take a systems orientation. So we're not, in MJTC, we're not talking about, we didn't come up with a technique that works with kids with psychopathic features. It's a comprehensive, multidimensional treatment system. And every aspect of the kid's life is part of the treatment program. And every aspect of the treatment system, the guys who pass him astray, take him to the shower, and so on, they're part of the treatment program. And so the intervention is focused on sort of the broad, these other approaches is focused on the family and the foster parents and those kinds of things. Those are part of the treatment system. On MJTC, the frontline staff are part of the treatment system, and probably I always get in trouble with the other psychologists when I say this, but I think the frontline staff are a much more important part of the treatment system than the psychologists and psychiatrists are. I'd rather see that part working well than see the psychologists seeing a lot of kids in one-to-one therapy. It's important what they do in their individual work, but this is, I think, the distinguishing characteristic of MJTC. The focus is, in addition to having this kind of focus on the social ecology that the kid lives in and the interaction patterns that kind of cause the behaviors to go the way they do, we also focus primarily on very kind of specific behavior change. It's a functionally based kind of approach. So we're looking at specific behavior problems and how to solve those problems. And that's true of all of these other approaches, MST and so on. Focus on specifically what's wrong and how can we kind of calculate a solution. Looking at the strengths that the kid has to the extent that we can. Active supervision basically means that in the other approaches, they're very selective about what foster parents they recruit and how closely they supervise those foster parents, how well they integrate them into understanding what the philosophy and theory is. And we do that with our frontline staff. It's not enough that a staff person shows up on time, they're sober, and they do all their paperwork and they don't do anything to get themselves fired. They need to be on board with the philosophy and the theory that we're working with, and that's going to be actively supervised by the staff. And basically, for those of you familiar with authoritative versus authoritarian parenting, that's what we're going for. We're trying to get the staff to work with the kid out of the framework of authoritative parenting rather than just authoritarian parenting, where you have consequences for failing to do things or you're held accountable for things, and there's a lot of reliance on deterrent sanctions. A few of these approaches use behavior management programs or contingency management programs. We do too. All of us do it the same way. We all have very short turnaround times, usually 24 hours. We call ours a Today Tomorrow program. Points the kid earns for his behavior today determines his privilege level tomorrow. So he can be at the highest privilege level on Tuesday after bombing on Sunday if he holds it together and does well on Monday. And so there's a rapid turnaround, and it's a very forgiving kind of system. At the same time, then, the problem is how do you get the kid to get any consistency in this behavior? All of these approaches then use some form of a step program. We call it our club levels, where if he pulls together several good days, then he accesses a set of privileges that he has for the next week, no matter what his daily scores are. So in our system, we have 3 club levels, and the basic concept is to try to get the kid to develop a social bond with the system, some stake in conforming with the system, and also just some basic kind of connection with the staff. We're not really talking about therapeutic attachment, those kinds of things. We're talking about just kind of the basic social bond that you have with your employer or with a teacher, or those kinds of things where you have basic cooperation going on. That's what we're really looking at. On all of these, when they use punishment, and we don't use it very much, and neither do the others, when it's used, it's very brief and focused, and usually focused around trying to reintegrate the kid into the system. The problem when a kid punches another kid in our system is that he's not with us anymore. He's not working with us anymore. And how do we get that relationship back together and get it working? Rather than just coming up with a penalty like security 1 status, where the kid is locked in his room by himself for 23 out of 24 hours for 6 days, say, and then he's out, and no one's talked to him, no one's trying to reintegrate him into the treatment. We also don't allow, although because it's a secure corrections facility, that's built into the way the corrections does things. If a kid punches another kid, then the requirement is he's in security for a period of time. When we have that occur, we have the kid is likely to get one-to-one contact with a teacher. A speech pathologist may go in. We're going to have one-to-one contact with a psychiatrist, a psychologist, and social worker, and so on. So he may be in his room for that 23 hours, but he's actually going to have a lot of contact. We really don't want a kid to basically be pulled out of treatment because he's displaying the symptom or the behavior that he's in treatment for. And so we try to step up or at least continue the treatment program when that happens. Another feature of all of these approaches is that they monitor outcomes continuously. So you boil down what's wrong with this kid to some kind of relatively observable behavior, and then you generate numbers and you track the frequency or the intensity, whatever it is, of those behaviors. And you monitor that both because You want, when the people make decisions about the kid's treatment, you want those decisions to be data-driven and not driven on the basis of who shows up for the staff meeting. In my internship, I had the opportunity to sit in on a program or work on a program. I have this vivid recall of our meeting one time where the psychiatrist changed the patient's medication. The staff person that were in the room said it hadn't helped at all. The person was no change. The meeting drove on for about 2 hours, and people walked out and walked in. And at the end, somebody said, well, how about this medication change for this patient that we had talked about at the very beginning? It had been so long that everybody forgot that we talked about it. And the new person had said, you know, it's really making a big difference. He's doing much better. And so the psychiatrist is left with, like, which rumor do I respond to? And so we want that decision to be based on actual numbers and actual data. If it makes a mistake, we'll make it that way. And it's important to the other aspect, all of these approaches rely on professionals who understand the philosophy and the system and the structure, and who, rather than having, for example, a treatment manual that lays out 12 steps and 3 phases and those kinds of things, and you adhere to it that way, we want the staff, professional staff, to monitor how things are going and make sure that the frontline staff are doing the right things and understand how this is supposed to go. So it's a professionally driven supervision, and our treatment integrity is ensured by essentially professional supervision rather than other kinds of things. That's about all I'm going to say about that, because we have done, as Kent mentioned, we've done many outcome studies, most of which have not been published, but I'm going to talk about a couple of the ones that we have published. Because we operate, even though it's a maximum security corrections facility, we actually operate it the same way we would operate an adolescent psychiatry unit. So when a kid comes in, he gets a whole lot of admission assessments. And so all of our dependent variables, including the PCL, were based on these fairly extensive interviews and diagnostic interviews and things that we would do up front. Now, very briefly, even though I totally agree with the caution people have about applying the label of psychopathy to juveniles and those kinds of things, the research so far shows that as you assess psychopathy with PCL-YB, that adolescents that have high scores do tend to have some of the same features that adults have with high PCLR scores, meaning specifically that they show poor institutional adjustment, meaning they fight with people and they destroy things and those kinds of things. They don't make as much progress, especially on behavioral point systems. They have higher recidivism rates on release, especially violent recidivism. One of the differences is that there's so far been no connection between a high PCL-YB score and propensity for sexual violence down the road in juveniles. There's some evidence that there is with adults. We scored all these, as I mentioned, from our admission interviews and that kind of thing, and we get pretty good rate of reliability on that. We borrowed Joe Newman's approach, and we get about the same results. And our scores look like a lot of people's scores. Basically, when a kid comes in, the PCL is one of the best predictors or post-dictors of the number of prior charges the kids had, the number of crimes against persons, their attitudes about delinquency and criminal sentiments, how much physical aggression they've used and their attitudes about physical aggression, the number of conduct disorder symptoms we see, how seriously they've injured victims. So a whole range of indicators of the seriousness, the intensity, and the duration, the durability of their behavioral problems, right up to including the number of conduct reports, the number of behavior problems they'd had in the institution that sent them to us. And also, our baseline behavior score is based on the first 3 weeks that they're on our unit. Our contingency management program includes up to between 6 and 10 rating scales that they're rated on per day. And so we take the first 3 weeks that they're in the full programming, and that's what we use as a baseline behavior score. And you can see baseline behavior in the same time frame of the first 3 weeks of being in full programming for security. The psychopathy score, or the PCL-YB score, is a strong predictor of all of that. So it's a valid measure. It's at least a good measure of how severe and intense the kids' behavioral problems are. Now, one of the studies that we did was a cost-benefit analysis, and so I'll touch on this because it was probably one of the more rigorous studies we did. We started out with, I think, 249 kids. 101 of them were in the treatment category. Now, I need to explain this a bit. Because we had this one sample of kids that would come, they'd send to, the other people would send to us for a medication adjustment or some kind of a short-term assessment or that kind of thing. When the kid walked in the door, they usually wouldn't even tell us. They would say, Joe's coming, here he is. And they wouldn't even tell us whether they planned to take him back at some point or what the plan was. And they would get around to it in a week or two. And by that time, we had done all of our initial assessments usually. So at the time we're doing the initial assessments, we don't know what the kid's status is going to be. It would be anywhere from 2 to 6 weeks before they would decide whether they would take him back. And so what I did with all of these studies was I simply took that group that was sent to us for just a short-term stay, and I compared them to the group who were sent to us for very long. And essentially, the sending juvenile corrections institution would send some kids and say, we never want this kid to darken our door again. You got him, we're never taking him back. And so we compared the group that was sent to us permanently to this short-term group. Now, the operating theory was that if the kid was treatable, if they thought the kid could respond to their program, they would take him back and work with him. And so in theory, at least, the kids in the treatment group, the MJTC treatment group, should be less treatable, or at least perceived as less treatable, than the kids that were sent for short-term assessments or those kinds of changes. So this particular study we followed for 55 months. These were consecutive releases, I believe. And we looked at costs of the treatment program and the costs of recidivism. In Wisconsin, you can collect circuit court information off of the internet as public record, so it's very easy to do. So we just went back 5 years, picked up 2 years worth of kids, and followed them up and did all these calculations. There were several things we couldn't get, like jail confinement. We didn't bother with pain and misery scores and stuff like that. Looking at the sample who were on the unit during that 2-year period, you can see that the treatment and the comparison group scores were on various kinds of measures were very similar. We tended to have an awful lot of kids from Milwaukee County who were clearly had mental health problems and had never seen a psychiatrist. And so we had more of those African American kids from Milwaukee County in the JCI comparison group, a higher percentage there. Otherwise, down the road, you could see down the line it was very similar. The two groups were very similar. This particular sample hadn't hospitalized or killed quite as many people, but that's right. When we did the follow-up, just without any controlling for any variables, without trying to match the groups or anything like that, this is what we find. And this study was about the 8th or 9th study we had done. And we find the very same thing in all of them, which is that we don't really, I don't have it broken out here, but when we broke it out to non-violent misdemeanor offenses, basically property misdemeanor offenses, we had no treatment effect at all. They were the same. Not really surprising because those things tend to be determined by local community variables and things like that. But as you went up to more serious offenses, and especially more violent offenses, you can see any violent offense, the treatment group had about half the number of violent offenses. This is offense incidents per youth. So you can see they had about half, and when we included violent felony offenses, because some violent offenses were misdemeanors, violent felony offenses, you can see is almost a little more than half in the comparison group. That's fine, but we haven't done anything to compare, to control for these two groups. For a lot of programs that try to study these in vivo kind of programs, and I could spend probably a day talking about the difficulties between kind of controlled laboratory tests versus in vivo kind of things. But for a lot of folks, they tend to diminish the value of this kind of study because you don't have controls. You don't know whether the two peak groups are really comparable. There is not a perfect solution, but a way to get around that, and that's called propensity score analysis, where you essentially create a statistical model. The problem is that the treatment group, there may be a bias in the group assignment process, where the treatment group, even though everybody thought they were less treatable, actually the bias worked the other way and they were more treatable. They weren't as bad as the other group. And so it's sort of just a sorting out process. And so what you do with propensity score analysis in a simple description, you simply create a statistical model of the decision to put a kid in the treatment group or the comparison group, of what goes into making that happen. Once you get that statistical model built, you can test it, look at how accurate it is, how successful it is. If it really does capture most of that decision process, and there's a bias in that decision process, well, it also captures most of that bias. And so now you've got the bias boiled down to some numerical value that you can use that you can control for. And so that's what we did. The way you do that, briefly, because I'm sure, because this is boring, you use a logistic regression analysis. We entered 21 factors into a forward conditional logistic regression. 7 factors entered the model, and they were kind of the factors you'd expect. PCL scores, the number of days that the JCI had messed with the kid before they sent it to us, those kinds of things. And the accuracy of the model for protected group membership was 86%, so pretty good. The ROC value for predictive accuracy was 0.884. So we got a model here that does a pretty good job of predicting that decision process. Now each individual gets as you do this, you save the regression value for each individual. So you've got that, the regression value essentially amounts to the value that reflects the propensity for that person to be put into the treatment or the comparison group. And I could explain that in more detail, but I won't. So what you do with that, what we did with that was we simply took a nearest neighbor matching strategy. The guy in the treatment group that had the highest propensity score was matched up with a guy from the comparison group who had as close to the same propensity score as possible. We went down the line and yoked those two individuals together. So now if there's a bias, it's evenly distributed between the two groups, as best we can do. Again, it's not perfect, but it's the best you can do. Commonly used approach, by the way, in healthcare. It's how they determine that lumpectomy is preferable to radical mastectomy in certain cases. It's the type of analysis that was used to establish that an aspirin could prevent a future heart attack, those kinds of things. So it's very useful in these observational studies. So this is after they're matched. You can see the PCL-YB score, our average PCL-YB score is over 32 for both groups. But you can see that it does look as though the, very, very similar level scores across the board. We get IQ scores about 85 is our average. And you can see an onset of behavior problems at about age 7. And that's usually because that's when they first showed up at kindergarten. And the first time anybody had any contact with them other than their parents. So they're closely matched. We didn't find any variables where there was a significant difference between the two groups out of close to 100 variables that we're tracking. So now we just did a regression analysis to look at, to determine whether the treatment effect, whether the treatment group assignment had an effect on the total number of crimes, total number of violent felonies, and total number of felonies. And we controlled for the amount of time the kid was out, the amount of time at risk. And basically, here's what you get when you do that. This is on the last step of the regression analysis, where we entered group membership after controlling for these other variables. And you can see that, once again, essentially a similar kind of pattern where we get a significant effect for all crimes. In other words, treatment seemed to have an effect on all crimes. But really, the big one was violent offending. Treatment accounted for 32% of the variance in violent offending. Also, just kind of an interesting side was that none of the treatment group members had been charged with a homicide in this 4.5-year follow-up period. And about 10% of the other group had been charged and convicted on homicide, totaling 16 deaths. These are very, very dangerous. These are not nice kids. At one point we tried to figure out how many homicides, what percentage of the total homicides were accounted for by kids that weren't treated on emergency. And then we calculated basically the cost of the institutional treatment, the cost of the crime, and the cost of prison, holding the kids in prison, and so on. You can see they're very expensive kids to treat. These are the worst of the worst, and they are expensive to keep them in. Wherever you keep them, they're going to be expensive. But because MJTC was very successful, the thing that we knew we would be able to do was we would be able to improve the kid's institutional adjustment. And once you improve the kid's institutional adjustment, he goes to groups more, he goes to school more, and he starts to make more progress, and so he got out faster. And so kids that they sent to us that we kept tended to have shorter overall length of stay in JCI, and so they only cost an additional $7,000. So the additional cost wasn't as big as it was expected to be. So for that $7,000 upfront additional cost, when you add in the cost of crime and the cost of prison and so on, you get back about $43,000 return in avoided criminal justice costs and things like that. That's a return, that's a 7-to-1 cost-benefit ratio, a return of about 130% a year. And of course, this kind of social cost-benefit ratio, those costs, those savings only go up. They don't go down like the S&P 500 does. So these are very significant savings to the taxpayer. Not very impressive to our governor at the moment. But, so what we have, this is one of a series of studies that we had done that showed that you could reduce the violent reoffending of these guys by quite a bit, by a very significant amount. The question was, what's going on? What's happening during treatment? Are the psychopaths, are the kids with high PCL scores, are they making as much progress as the other kids, or is most of the benefit coming from kids with relatively low scores, or what's going on with that? So we had 86 new participants, new kids that we hadn't studied before. We brought them in, we looked at their PCL scores, the average PCL score, the median PCL score was 31, so we cut the group in half. The guys high, that scores over 31, guys that were 31 and below, so we had two groups of 43. And now we looked at these behavioral points and their security stays as they went through the pre-treatment program. And we wanted to see whether there was PCL had an effect on what kind of progress they made. And I'm not going to go through, well, this is a kind of graph that we're talking about. This is security time. It's a very typical kind of graph that we see with the kid on MJTC, where he starts out having a lot of problems and gradually improves as time goes on. This is our daily behavioral point sheet, and this again is very typical where a guy, you can see an awful lot of fluctuation that can lead on a day-to-day basis. If you don't have this kind of data, it's hard to tell whether you're getting anywhere with the kid. When you've got this kind of data and you can aggregate it on a weekly or monthly basis, you can see the graph improving. And so it has a number of benefits. So what I did with these data is just a simple 2x2 analysis of variance. Time 1 was the admission score on the behavioral and security time, and time 2 was the final 3 weeks before the kid was released. And we looked at high and low PCL to see whether it affected that. And here's the punchline. Let me explain this a little bit. What this shows is we have 2 time periods, the first 3 weeks and the last 3 weeks. We get what's called a main effect for time, which means that the whole group, both groups, improved over time. They all got better to some extent. We also got a main effect for PCL, meaning that the guys in the high PCL category were worse on admission, had lower behavior scores on admission, and they also had lower behavior scores in the last 3 weeks before they were released. But we did not get what's called an interaction effect, which means that the guys in the high PCL score group improved just as much as the guys in the low PCL group. There wasn't any sign that PCL blocked progress in the treatment program. They seemed to do just as well as the other group. So that's fine, but we were interested in, I'll skip this. We were also interested in testing this one hypothesis, which was that maybe the guys in the high PCL group are conning the system, and they know how to behave, they know how to kind of con their way through. So they control themselves and they con their way through. And once they get out, they're going to be just as dangerous as ever. This is a popular theory in Canada by people I've ever mentioned. And so, if that was the case, then the final 3 weeks of their behavioral scores should have no relationship to violent recidivism, and the PCL score should still predict violent recidivism, just like it always does. So we did that. We ran the analysis. We took a 4.5-year follow-up period. we just entered the PCL's total score, were entered in the regression equation. This was a Cox proportional hazard analysis for those that are interested in that. And we looked at whether the PCL score was a better predictor of violent recidivism or the final behavior scores were a better predictor. And what we found basically was that the final behavior scores was, I would say, a weak but statistically significant predictor of violent recidivism. The PCL score did not predict violent recidivism. So what we have now in this study is the PCL score was one of the best post-dictors of all kinds of the age of onset of behavior problems, the variety of behavior problems, the intensity of behavior problems, how badly they'd injured people, all the way up to and including the first 3 weeks on the unit. And then, from that point forward, the amount of progress they made on MJTC and whether or not they violently recidivated after they left MJTC, all of that was determined by treatment variables, by how long they were on the program, how much progress they made in the program, and so on. So that was interesting. The next thing that we were interested in is, okay, so if that's shifting, we need to start thinking about whether we're actually changing characteristics of psychopathy in this process. And so we took, again, kind of a convenient sample of 248 consecutively released kids. And we broke out, this was a group that we had studied earlier before the PCLYB was published. And so after it was published, we had these facets to look at. I thought, well, let's take a look at that. So we split these groups into high and low at the median score, into high and low scores on each of the facets. And we looked at behavior change and violent recidivism, behavior change during treatment, and violent recidivism for each of the facets. This will hopefully make more sense when I show you the charts. So this is an example of behavior change in the program for the kids with the interpersonal facets. And you can see that on admission, we have even a more dramatic difference between the guys with the low interpersonal facets were really doing fairly well, kind of relative. They were getting like D minuses instead of F minuses, but basically doing considerably better than the guys with the high scores. Over the course of treatment, that really seemed to be neutralized. And so we have a significant difference in the admission and final scores based on interpersonal facet. Now, we did not see that, even though it looks like you might have it here. This was not statistically significant. But, and we didn't have it for either the antisocial facet or the behavioral facet either. It's not surprising with the behavioral facet because most of those are historical characteristics. So the interpersonal facet, again, is that facet that deals with lying, conning people, just manipulation of people and using them and tossing them away, those kinds of things. The other facet that I think is the source of the focus of a lot of interest is at the affective facet. This is callousness, unemotional kind of things, failure to attach to their sort of shallow affect, those kinds of things. And for us, at least, the antisocial, the interpersonal facet seemed to be the place where we saw the most movement in the treatment program. We saw, again, this is for security restrictions, and you see essentially the same phenomenon. Treatment seemed to neutralize the effects of having a high interpersonal facet score over time. Not really the same, well, actually now I'm not recalling whether this was significant or not. But for the behavioral and the antisocial facet, we did not see it to the same extent. I think the more important or the more interesting part of this was when we looked at violent recidivism over a 5-year period after the kids were released. And in the interpersonal facet, we again used the same process of the comparison group versus the treatment group. And you can see here that the kids with in the comparison group, you got exactly what you normally would expect. The guys with the higher interpersonal facet had more violent offenses, and the guys with the lower interpersonal facet had less. The treatment group, not the same, not so much. They were, the two groups were about the same, regardless of their score on interpersonal facet. We did not see it with that effect with the affective facet, and we got this kind of squirrely results in the behavioral facet. Behavioral facet is a lot of that is loaded on historical kind of behavior. and the same with the antisocial facet. A lot of it relies
So
on
Mike, in all of those, you're seeing a huge treatment effect.
Right, in all 4 facets, yeah. And that's because, of course, as I said earlier, as I showed earlier, yeah, we saw across the board for the total PCL score a substantial treatment effect when it came to non-recidivism. So it looks like, now this is not too much of a surprise, this is one of those kind of post hoc interpretations, but the program, MJTC, focuses a lot on the interpersonal interactions that the kid has. The belief is that we kind of, especially as an adolescent, you kind of identify who you are by how people relate to you and how you relate to others and all of that kind of thing. How you know, in a lot of ways, teenagers will, for example, define who they are in opposition to an authority figure or those kinds of things. And so we focus a lot on interpersonal processes in the program. So it may be that what we're seeing here with the interpersonal facet may be sort of an artifact of how this is the part of the field that we plow, and so it's not too surprising that that's where the crops come up. So it may be a function of how you get into these kids. But that may be important by itself. This may be a door that you can go through to work with these kids where other areas may not be as easy to get in. We took basically the same approach with the antisocial processes screening device, which has the advantage of being a self-report, having a self-report version. So you can do it with repeated measures. And so every 90 days, we give these kids a series of tests, a series of questionnaires about their symptoms and various other things, and including the antisocial processes screening device and some other measures that I'll talk about. So we collected the data within a week or two of admission, and every 90-day intervals after that. And again, this is just repeated measures analysis of variance. What you should see here is that over that 90-day period, we get a significant improvement in the total score, callous and emotional symptoms, narcissistic symptoms, and impulsivity. And so the scores improve, and I'll show you some of that. The scores for the total score, you can see a significant improvement there, significant improvement in callous and emotional symptoms, also impulsivity, but when it came to narcissism, the first 90 days we got relatively not much movement. The first 90 days is a non-significant change. It's after the first 90 days that we start to see some significant change. So that fits with actually some other data that we've got that I don't think I'll have time to show, but I'll try. Where there are certain things that seem to change first when you're working with these kids, and other things that are more downstream. And when you think about narcissism, that's how the kid views himself and how he fits into the world, and all those kinds of things. When you look at something like impulsivity, for example, it's something that you're going to be more likely, if you're able to do something effective, you're going to be more likely to make a change with the level of impulsivity on a short-term basis, and you're going to have some of those things in place, less impulsivity, better interpersonal interactions, and then at that point you may start to see changes in the kid's worldview that may start to challenge, maybe the way I've understood the world isn't quite the same. At least that's the theory, that if you can change the interaction patterns, then down the stream you'll start to change the kids' attitudes about who they are and how the world works. We then looked at whether these changes had any effect on the kid's behavioral score. These are the same, we're looking at the same final behavior scores that previously predicted violent recidivism. These kids haven't been out long enough for us to do the follow-up study, but and what we find here is, of course, that across the board we got a significant relationship between the change in the behavior score, in the APSD scores, and improvement on the behavioral scores. And the biggest bang for the buck in the factors area was with the callous and emotional symptoms. And so now, partially this is because the APSD does not split out interpersonal processes and callous and emotional symptoms very well. They tend to overlap. So we may be seeing both of those together at that point. But again, narcissism was the area that we had the weakest, but that's still a significant effect. We started to use the, it's called the Index of Callous and Emotional Symptoms, Paul Fricke's kind of new scale, focusing specifically on this issue of callous and emotional symptoms. So it's an area that we just do not know enough about. We need a lot more work on what we're talking about with callous and emotional symptoms, how to measure callousness, what types of callousness you're dealing with, and so on. So, and how much callousness might be acquired through the kids' experiences, how much it might be affected by the kid's sense of reality, and how much of it is just a deficit in the kid's ability to understand other people's emotions. There's other possibilities, but in any case, we see a significant change in the ICU total score, but again, not really a movement in the first, not a significant movement in the first 90 days. It comes really in the second 90 days. And when it came to callousness, we had the highest, the largest change on the callousness scale. No significant difference on emotional. They reported pretty much the same kind of results across the board on how emotional they were. Now, this is a little bit confounded. There's been other people that have found this. Confounded by the fact that a lot of these kids, when you talk to them about emotion on admission, you say, you know, are you an emotional person? They usually would say, well, yeah, that's why I get in trouble all the time. My emotional expression usually involves firearms. So they're being trained, a lot of work being done to make them less emotional and kind of calm things down. And so I'm not sure that this is, I think we have some instrumentation problems with that. But in any case, when it came down to caring, again, we don't have a significant change in the reported degree that they cared about other people, those kinds of things. So they have a sense, they report at least an improved sense of the suffering of other people and that kind of thing. But that's about as far as that goes. Now, let me just real briefly talk about the aggression questionnaire. We were interested in the aggression questionnaire for two reasons. One is that the physical aggression scale of the aggression questionnaire significantly post-dicts the level of worst victim injury in our samples. And so a kid who, the physical aggression scale is a scale that measures how much the kid has attitudes supportive of physical aggression. Every now and then, let's face it, you got to beat the hell out of somebody every now and then. You've got to stand up for your rights, and that means you got to be violent. And so that seems to match, at least with our samples, that matches up with level of worst victim injury. So we're interested in that, but there's also a couple of scales in there that seem to relate, or look like they may be rough proxies for reactive versus instrumental violence. And I'll talk a little about that as we go. This is what we get with the physical aggression scale, and you can see a fairly significant drop. In the first 90 days, we get a big drop. Each of these steps are statistically significant. Anger is a reactive anger. So this is a scale that should relate to reactive aggression. These are the kids with short fuses, blow up easy, and you can see again we get a statistically significant change in each of these 90-day time frames. Hostility is a hostile worldview that other people have murder in their heart, that you're crazy to do anything altruistic, that other people have a malevolent attribution or a malevolent bias towards you, or have malevolent motives towards you. And so this should be related to some extent to instrumental violence, because if everybody out there would kill you if they had the chance, then you're justified in planning to do things that are violent towards them. And again, we get a move, regardless of all of that. Aggression questionnaire hostility is clearly a worldview type of measure. And again, our major change doesn't come in the first 90 days, it comes downstream after we get some other kinds of things changing. So that's where we stand right now. We have a number of other studies in the works that we'll be looking at. I surprised myself that I managed to get a little bit of time for questions here. So are there any questions that I could maybe address?
First, let's thank
Yeah. So
we tend to follow it out to about 6 or 7 years at the most. And the reason we don't go farther is that we find that, the violent kids that we deal with, at least, when you compare with the results you get in 3 to 5 years, and then you add on what you get if you go farther out, you get about 95 to 98% of your violence in those first 3 to 5 years. And so you don't gain much by having a much longer follow-up time. And the trends between a comparison and treatment group are usually established by year 3. And so we just don't have a lot of need to go farther than that. Any other?
Yeah. And it may be because it was late. Could you tell me what your age groups were?
Yeah, the program will take kids, we've had kids as young as 10, and guys that have been as old as, we had a guy who was actually 21, but he was passing himself off as 19. And didn't get caught until after he got out. But our typical, the group on the unit right now runs about age 13, 14, up to about age 17, 18. Our average age is about 15 and a half. And in Wisconsin, the juvenile court supervision goes up to age 16, and at age 17, they're in adult court. So, so counties tend to let the kid, push the kid out at that point.
So if your argument is that you can make some treatment inroads with young people that are showing psychopathy, would it be accurate for me to assume then that may be related to the fact that their social repertoires have not been affected? I mean, this wouldn't be, would your argument be that this would also possibly show benefit for adults?
I think it could. All of us that planned MJTC had previously worked on adult forensic units with very aggressive adult offenders. And so all of the principles that we brought to MJTC, we had developed and worked on in that sample. So I should put this in the framework that I am the pessimist on MJTC. I'm always skeptical that our results are what they are. But I think this approach could certainly improve institutional adjustment considerably. I bet on that. Sort of the surprise with the kids was that improvement in institutional adjustment also seemed to translate, if you did it right, into improved community adjustment when they were released. So the short answer is, I don't know. I think it could benefit. I think it could work. I don't think it's going to be as effective with older guys as it is with the juveniles, because these kids, even the more very psychopathic kind of kids, are not as sophisticated in conning and those kinds of things. They aren't as committed to it. They haven't burned years of their life doing this. They can make a change easier.
So if you were to try with first-time adult offenders, or they could have been juvie too, but what I mean by that 18, 19, 20,
yeah,
that where you would start, or would you?
The younger the better, to start. But and I've worked with a lot of offenders in outpatient settings. It seemed to me there were windows where, and one was right around 30, where the guy realized that he had basically pissed away a lot of his life, and he was ready to, and he'd calmed down a little bit, and he was maybe ready to make a change. It's a tough age to make a change because you've burned a chunk of your life. But I would bet you'd get the best results with younger offenders. But there may be times down the road like that where there's windows where you can get some real movement with older offenders too.
So that's fascinating. Sorry, I'm going to go away from what you're saying. So we try to predict behavior, right? And so there's all this economic work that looks at consumer behavior in terms of there are certain time windows when people will, you go to college, or you have a baby, or you get married, that you can completely change how you consume or buy things. You'll switch from 10 stores to 1. Yeah. For example, you'll do these types of things, and they know this. Of course, Target, Walmart, they learn this, and that's when they target ads towards you. Yeah. So the question is, do you know of any other way that you can try to figure out how and when it might be most efficacious, or does it have to be just a self-report? Because they'll all tell you, I'm ready to change, right? I mean, you talk to them, I'm ready, I'll change. And then maybe in research they tell us, I'm not really ready, But the question is, can you think of any way you might identify that window that they might be susceptible to change, older than in 20s?
Nothing comes to my mind. I mean, when I was working with offenders outpatient, it would be the guy who came in and would say, I ran into the kid that I used to beat up in junior high all the time, and he's driving a real nice car, and he's got a real pretty wife and stuff like that, and I'm still having to drop urines and stuff like that, and being treated like I'm in junior high, and that kind of a wake-up call. But obviously, some guys would blow right through that and stay. And so, I don't know. The other thing is that I couldn't identify any features on admission of our kids that would tell me which kids were going to respond to treatment and which kids weren't. And so, not psychopathy, not IQ even. I don't. When they would come in the door, I would not know which kids were going to respond. And in fact, in these follow-up studies, there have been several times where I've been really surprised with kids that I thought I would have bet my car that this kid was not going to make it out of the parking lot without an offense. And we follow him 4 or 5 years later, and he's got a shoplifting or something like that. That's all. And that has been true with our clinicians. Our clinicians, when they recommend release, or when we look at that, how confident they are to release a kid or retain him or those kinds of things, has no relationship to recidivism. So the therapists are terrible predictors of progress, of what's real progress. And actually, I think part of that is because, psychopaths that are making progress still come in and say, I want a job like yours where I just sit around all day and don't do any work. They don't value you, they don't value the treatment, they don't do any of that stuff. And so the therapist thinks, well, they're not making any progress, I don't find any better. So, and of course, that's not really where the change happens. Yeah.
Wow.
I was interested, has this had any effect on the political process in Wisconsin?
MJTC has a bizarre kind of relationship with the politics. Our new governor, who is I think safe to say extremely conservative, increased the budget of MJTC this year. He likes MJTC because it's maximum security and it deals with the most, the worst of the worst, and allows the regular JCI units to just pick their worst kids out and get them out of the building. And so very conservative, kind of hard-line guys like it because of that. More liberal, treatment-oriented people like it because they see the results and they like the treatment part of it. And so we end up kind of right in the middle where everybody seems to like it so far. And even though, one of the things is, though, if you're going to start a program like this, you have to realize you're going to have some bad outcomes, you're going to have some bad events. And so you have to have a plan for that. And we did that. And so when we've had bad events, we've had a proactive plan in place on how we're going to deal with that, who we're going to connect with in the higher-ups in the government, and how we're going to keep the program from being shut down because of one bad headline.
Are you able to give this kind of talk to the politicians?
I don't get asked to do it very much. I get asked to do it to the judges, the juvenile court judges in Wisconsin, and I think it's persuasive to them. One of the problems that they have is that, they're a judge and they say, well, I want to sentence a kid to MJTC, and of course they can't. They sentence them to Division of Juvenile Corrections, and they do whatever they feel like they want to do. And so that neutralizes some of the impact. But we started with 43 beds. The month that the cost-benefit analysis that I just showed you was accepted for publication, we got a call out of the blue saying we're closing down a 30-year program and we're going to 29 beds because your beds are awful expensive. And so, so we estimated that's cost the state about $2 million a year since they closed it down. And there's been absolutely no interest in reopening it and adding those beds back in. So
how do you discourage it? It is. So that's one of the things I've always been fascinated by, is that you have to get someone to invest up front in order to get the payback.
Yeah.
And you show a return on that investment in as short as a year, right? 135% or something you said, in terms of, because they get out faster, right?
To get out. So it doesn't, the per diem cost of the beds is more than, it's just a little more than double what it is in the JCIs.
Okay.
But, so on a daily basis, it's twice as much, but they get out faster because they make progress.
Right.
And so it doesn't actually cost overall that.
And then they don't come back.
And they don't come back and they don't kill people.
Right.
Killing people is very expensive.
Right, it's $1 million.
And life sentences are real expensive. In that study, by the way, the guys with the life sentences, we cut that follow-up time off of 4.5 years. So we got 16 or whatever number it was, were facing life in prison, and we didn't count that, we didn't prorate that out.
Right, I know you didn't include that.
Yeah, so the cost was even more. Yeah.
Question, is there any kind of evaluation that takes place when somebody enters the juvenile justice system
Yeah.
that can take place?
The regular actually they've got a fairly decent, what they call admission evaluation report process where that is modeled on the level of service inventory. And so a social worker does an interview, reviews records, and writes a report that lays out those risk factors and that kind of thing. It's like a lot of correction settings, like a lot of institutional settings, where they have sort of a push button treatment plan, and it's individualized in terms of whether you push button A, C, and D, or button A, B, and C. But
so there's no indication really, so that evaluation process doesn't have any connection with who goes into this treatment. It sounds like it's pretty arbitrary. Huh.
It's not arbitrary. It's if a kid in the JCI, the kid comes in and he goes to an assessment cottage. They evaluate his needs and stuff like that. Then he goes into a treatment cottage. He selects somebody in the treatment. Usually, our kids usually select somebody in the assessment cottage, but they select somebody in the treatment cottage. They go to a security cottage, and the security cottage kind of winds them down. They keep getting tighter and tighter security. And at some point, the people say, "We're getting absolutely nowhere with this guy." He gets on the list, and they get rid of him. They send him to us. There's some exceptions. A kid comes in and he's floridly psychotic. A kid shows up with cancer, and it's going to cost them a lot to treat him. They get rid of him. Those kinds of things. But mostly, that's the picture.
I think her question, though, and that's kind of a question I had, is getting there is more incident driven than it is diagnostic.
Yeah. Oh, yeah. Absolutely. Yeah. Only about, what would you say, just about 5 to 10% of our guys have significant, like schizophrenia or bipolar disorder.
Yeah.
Not more, certainly not more than 10%. It's overwhelmingly it's kids that are Jesse Peterson is a research assistant on NJTC. Yeah, so it's mostly kids with conduct disorder and ADHD.
So you said, did you start a clinical training program with Wisconsin? Are you having that internship program? Or my point that's leading into, do you think you could replicate it in other states?
I think we could replicate it. The difficulty with MJTC and actually some of these other programs is the fact that it is a multidimensional treatment system. And so you have to have everything from the physical plant to the staffing, all aspects of the program have to be considered as part of it. Yeah. So it's not as easy as just hiring some good clinicians, developing a 12-week group, go in, deliver it, come out. It's more complicated than that.
So do you think part of the success was that it was on the grounds of the mental health hospital?
Absolutely, yeah. Actually, and the people at the JCIs that at the time would shoot me if they heard me say that. But I think had we put them, had this been on the JCIs, the philosophy and the theory and how they approached things, like the training, the whole thing, would have just been another Supermax kind of situation.
So you've got a non-random selection of the psychopathic population. These are the worst, at least by somebody's. Do you think it would work with the more functional, less violent folks out there?
Yeah, I think it would work better with more functional folks. I think it would be harder to show treatment effects because you wouldn't get as much change. Yeah, it's easier to, in some ways, it's easier to demonstrate treatment effectiveness with sicker people. But yeah, I think it would work better with easier kids.
It's amazing to me that you're not getting more of a political bounce. I mean, you got 10 less homicides, so that one slide.
Yeah.
I think the
16,
newspaperman would be interested in a story about that.
Yeah, and we have.
Well, I have to tell you, I